Hi, everybody. Okay, we are going to talk about pregnancy and oral health. I want to let you know that this whole chapter in the fifth edition is really completely different from the fourth edition. In the fourth edition, I had made a PowerPoint on women's health, and that sort of went through teenager and puberty all the way to older women and osteoporosis and menopause. So this, I'm not sure how it's broken up in the fifth edition, frankly. I think that maybe some of that may be in the children and adolescent and in the older adult. So I feel like the topics are separated quite differently when it comes to this one topic. So I did leave a few things specifically about pregnancy in this slide set that is not in the fifth edition. But only because I feel like it's not wrong and it's not it's topics or it's material that is considered more like conservative. So I don't think it's wrong, and you'll see what I mean when I get down there. Let me just start, and then I'll refer to it back when we get to those slides. So here are the objectives for this chapter. And this is chapter 46, I believe, in your textbook. I think it's 46. So pregnancy and oral health, dental hygienists play a critical role in educating and providing oral health care to pregnant women. Physiologic changes in pregnancy may increase a woman's susceptibility to certain oral conditions. Pregnancy provides a really great teachable moment for the dental hygienist to counsel women about positive oral hygiene, nutrition, and just prevention in general for themselves, but also for early childhood caries for their child or for their current children and for their future child. Dental providers should work in collaboration with prenatal health care providers to ensure that the patient is receiving optimal oral health during their pregnancy, before and after delivery. So it's just a really great opportunity to have them think outside of themselves, so they're doing something good for them, not just for themselves, but also for their unborn child. So it's just a really great opportunity for people to sometimes find motivation that they didn't find before. So these are some key terms in the chapter: prenatal, teratogen, organogenesis. Gravid is generally referred to as being pregnant. I'd never actually heard that term. Gestational diabetes, oral health literacy, and then a teach-back method. And I think the teach-back method is something that's going to be reviewed. It's a communication method that we use as healthcare providers to confirm that our patient heard what we said. So it's like, can you tell me what I just told you, or can you tell me what you heard or understood? So then when they relay it to you, you can kind of modify and say, oh, that was great. The only thing I would add to that is X, Y, and Z. So oral health is vital to a healthy pregnancy. Pregnancy is an opportune time for women to adopt healthy behaviors, including those that relate to oral hygiene practices, nutrition, and routine professional oral health care. It's important for dental hygienists to ensure women that oral health care during all trimesters of pregnancy is safe, including dental radiographs with proper shielding for both themselves and their developing fetus. I think that this is one of the places where the texts sort of diverge from the fourth edition and the fifth. And I looked up some other resources, and the general, and I'll repeat this again later in the slide deck, but the general consensus is dental radiographs are safe as long as it's incredibly conservative and only happening when it's absolutely imperative that they have an X-ray to treat something that is affecting their general health or is only going to get worse if they wait 9 months to a year. Because you have to remember, the first 3 months after they have their baby, they're not going to want to come in like a month later. They're going to be tired and busy with baby. So it's oftentimes a better plan to address something while the mom's pregnant conservatively and making sure that they're addressing just what needs to be addressed and not doing things that are elective and not really necessary. So that's something that's sort of a slightly different message than what we've heard in the past. These are breaking up the trimesters. The first trimester is really the most delicate trimester. The baby is doing so much huge cell division and changes that they're more effective to environmental damage than during the second and the third. So if they get some kind of a chemical or an environmental toxin or something like that during the first trimester, oftentimes that's the time when you could see the most changes. And if we refer back to teratogen, it's an agent or factor which causes malformation in the embryo. So and those are caused from outside sources, and those things are most susceptible during that first trimester. So educating the pregnant mother, the mutans streptococci, or the strep mutans that we know cause so much of the disease in the oral cavity, it's important for us to educate the mom about their transmittability. So the vertical transmission from a primary caregiver, usually it's mom, but it could be whoever is around the baby the most, through saliva, activated by frequency and the amount of exposure. Infants whose mothers have high level of strep mutans as a result of untreated dental caries are at a greater risk of acquiring the organism earlier than children whose mothers have a lower level. So therefore it's really important for pregnant women who they should have all of their caries treated, hopefully before getting pregnant or during the pregnancy. It's safe for them to have that dental treatment and get those cavities fixed and get their mouth in a healthy state. Then there's the horizontal transmission, which can occur. That involves the strep mutans going from another family member or from another child, so like a sibling or somebody that comes around not as often, or perhaps like in daycare. Improving the mother's oral health will in turn improve the child's oral health in the long run. So this is a concept that is really important for moms to understand. So especially when you see the moms putting the pacifier in the mouth, or licking their spoon and feeding the baby with the same spoon, they're transmitting that bacteria to the infant and populating their oral microbiome with more bacteria at an earlier age. So if they don't have that understanding, then then their child may end up with more caries, more early childhood caries. Okay, so let's see. So periodontal disease and preterm labor. So we know that about 40% of pregnant women have some form of periodontal disease, and there have been studies that correlate untreated or poorly controlled periodontal disease with like preterm labor or some kind of an adverse pregnancy outcome. However, in 2017, a Cochrane review found that when pregnant women with periodontal disease who received periodontal treatment, when compared to those who did not receive periodontal treatment, for one, there was no evidence that treatment of the periodontal disease reduced the number of babies born before 37 weeks of pregnancy. However, there may be fewer babies born weighing less than 5.5 pounds. So the evidence shows the evidence is showing a cause and effect relationship is lacking overall. So they haven't, it's sort of like the jury is still out on this topic. But we do know that the hormones and all those things do have an effect on their overall oral health and their reaction to the bacteria. So it's still a very important topic to discuss, and because it could potentially affect pregnancy, it's still important for mothers to know this. So here's a slide from my last slide deck. So this was based more on the fourth edition of Darby and Walsh. So research has been indicated that periodontal infection may be a possible risk factor for the preterm or low birth weight infants. The topic is still under debate. That's what we kind of, the new text is sort of pushing that a little bit more to say, we really don't know that there's a direct correlation. But the theory is, and I think it's important for you to understand the theory, that's why I left this in here, that infection causes a increase of the prostaglandin E and the tumor necrosis factor. So we know this about and how it affects lots of other things, and how just a chronic infection in the body is not healthy for the body. So these molecules, they hypothesize could possibly induce labor, and that's because the PGE, or the prostaglandin E, is a similar chemical structure to Pitocin, oxytocin, and they use Pitocin to induce labor. So non-surgical periodontal therapy is safe. So like I said, it's only conservative. If you're concerned about this and you want to tell your patient about that, you don't want to scare them and say, oh, you're going to have a preterm labor, or a low birth weight infant. You don't want to tell them that with all, like it for sure, but it's good to be precautious and tell them that periodontal therapy isn't going to do an adverse effect to your pregnancy, and if anything, it might be beneficial. So it's better to err on the side of caution. Let's see. Oral manifestations during pregnancy. So we have a couple different things that we know we see. There's an increased inflammatory response to the bacterial plaque during pregnancy, and it causes signs of gingivitis in most women, with the anterior teeth tending to be affected more than the posterior teeth. These signs are exacerbated by poor plaque control and mouth breathing too. Pregnancy gingivitis typically peaks during the third trimester, and women who have gingivitis before they got pregnant are more prone to pregnancy gingivitis. So if they're already struggling with gingivitis, all of those hormones and everything just tends to exacerbate it and make it worse. Benign oral gingival lesions. So in approximately 5% of pregnancies, they might get a highly vascularized or hyperplastic. It's often pedunculated, so it has that sort of like a mushrooming and then like a smaller stem that's attached. Lesion. It's a lesion that can be up to 2 centimeters in diameter. Usually around the anterior area, and these lesions may result from heightened inflammatory response to the oral pathogens, and they usually regress after pregnancy. Sometimes they have to be excised, but that's not very common. If they need it to be excised, it could be because it's causing pain or it's interfering with them eating. Maybe they're snagging it when they want to eat something. So they might have it surgically removed, but it could also return. If it's early in pregnancy, they may have it come back again before they've had the baby. Tooth erosion. This can be from just the acidic environment in the mouth. If they're having lots of bouts of nausea and vomiting or hypermesis, gravidarum, that's just like excessive, they can't keep anything down. They're throwing up constantly, and sometimes these women can actually be hospitalized because of it. The other thing too is if they have xerostomia on top of that, and then the increased acidic environment can really increase that erosion. So, or just the heartburn. Oh my gosh, in the later parts of pregnancy, women can have a lot of acid reflux and heartburn, and that can also play a part. And I had a note about encouraging women to, if they are dealing with a lot of vomiting or acid reflux, to rinse their mouth with a baking soda rinse. They can do like a cup of water and like a teaspoon of baking soda and swish that around twice a day, or every time after they've thrown up, if they are actually throwing up, and that will help with the erosion. Dental caries and tooth mobility. So dental caries has been associated with just this the snacking and the high sugary drinks. Sometimes their diet can get so thrown off because everything makes them nauseous except for maybe a few things that they eat a lot of. Or they need to snack a lot to help with the nausea. So things like that. So they have to be aware of good oral hygiene practices, rinsing their mouth, maybe using a little bit more fluoride or xylitol. Tooth mobility, increased tooth mobility has been associated with microbial shifts from the aerobic to anaerobic bacteria. These shifts are accompanied by increased inflammation in the attachment, the PDL, as well as mineral disturbances in the lamina dura. So this condition appears to reverse after pregnancy. So again, it's just some changes in the body due to pregnancy. So they may feel like things are moving or like wiggling or something. And we can reassure our patients that things go back and kind of settle down after the pregnancy is completed. Periodontitis, untreated gingivitis can progress to periodontitis, and then it can, affect permanently their alveolar bone, the PDL, the structures around their teeth. And so it's important for us to, especially if they have had some kind of very mild periodontal conditions prior to getting pregnant, it's important for us to educate our patients about their risks while they're pregnant, during pregnancy, and after, especially if they're having trouble keeping on top of their self-care because they're just exhausted or feeling anxious or feeling sick all the time. They don't want to come and see the dentist because they just are so uncomfortable, or their pregnancy is a difficult pregnancy. So it's important for us to be a support and to help educate them during this process. Oral disease prevention and health behaviors during pregnancy. So a couple things that we want to really encourage our patients is to stay hydrated for a number of reasons. Their doctors are going to tell them this all the time. Drink lots and lots of water. You need hydration for you. You need hydration for your baby. Meticulous oral hygiene, using fluoride and xylitol, limited fermentable carbohydrates and sugary drinks, taking a prenatal vitamin or supplements. The DHEA is like a fish oil. It's good for baby's brain. Fish is highly recommended for pregnant women. I think avoid is misspelled. Sorry about that. Ovoid, raw meats, and high mercury fish. So I really like this little schematic in the 5th edition. You guys don't need to know this for a quiz or an exam, but figure 46.1 in the textbook kind of separated healthy fish options and then the ones to eat less of and then what to avoid. So that's a really important, I think, for patients to know what is the healthy fish options, like canned tuna fish, whereas like sushi or something like that is to be avoided during pregnancy. Chlorhexidine and xylitol are also recommended and are safe during pregnancy. Let me see if here's my notes here. Let's see. Dental providers often recommend the use of chlorhexidine and fluoridated mouth rinses and xylitol-containing chewing gums to decrease oral bacteria. No adverse effects have been reported with these products during pregnancy, but they have to be studied more. So it could always change. Next year we may say something different, but as far as, we know currently they're safe. For patients with vomiting secondary to morning sickness, if they have that hypermesis gravidarum or the gastric reflux during late pregnancy, the use of antacids or rinsing with a baking soda solution, so 1 teaspoon of baking soda dissolved in a cup of water, may help neutralize the acids. So I kind of said that earlier, but just to reiterate it. Professional oral health care during pregnancy. Oral health care is really considered very safe and super important during pregnancy. And I think that's the message that just needs to get out to the patients, is that everything that's done in the dental office is really okay. Their doctor is going to tell them what medications are absolutely big no-nos and things like that. So they're going to have that information as long as they're having regular prenatal care. It's important for us to know what medications are safe and not safe as far as pain medication and antibiotics, and local anesthetic and nitrous and x-rays. It's important for us to know that it's okay, but to be conservative, but to address disease. It's all a balance. So we should consult with other healthcare providers as well if we have concerns or we just want to double check. And then pregnancy and poorly controlled pre-existing diabetes, we want our patients to understand that if they come into a pregnancy with poorly controlled diabetes, that there are higher risks to the baby and the developing organs of the baby. And so we want to, if we have a patient that we already know has poorly controlled diabetes and they're all excited telling us that they're trying to get pregnant or that they are pregnant, they just found out they're pregnant, then those are wonderful opportunities for us to remind the patient of that bidirectional relationship between diabetes and their oral health and their overall health. And then we also want to be sure that we let them know about gestational diabetes as well. So if they don't have pre-existing diabetes, we still want to let them know about their risk for gestational diabetes, and generally in the usually around the 24th week of gestation. So, and the prevalence of gestational diabetes is as high as about 9 or 10%. So, and those are things that are going to be tracked again with their regular prenatal care. Their doctor is going to track that. But it's a wonderful tie-in for oral health because we know we have that link. And so these, again, are wonderful tie-ins for us to talk to our patients. Be prepared to educate the patient about the bidirectional relationship between oral health and diabetes.